y'all can.
Oh.
We're up. Let it kind of clear out a little bit. And make sure nobody just when you start talking, they'll start walking.
Make it a big production.
Now the worst thing is they trip over my cords, and we had somebody kick a cord out right before, and it shut everything down. And actually, it was the doctor who kicked it.
Oh, that's great.
And then he said, "Well, you better move it because I'll kick it again." And I went, "No, you need to stay behind the podium."
Yeah, I'm historically a walker, but I won't for this.
Like I said, people tend to drift. I just kind of point over.
Yeah.
Point you back over.
And we end right at 1 or 5 till, or you want
about
questions?
Five till and ask for questions.
Yeah.
If
Okay.
you'll repeat them to the audience,
Yeah,
so
'cause that way
this
everybody
audience
get
can hear you.
Good.
Okay. So
All
whenever
good.
you're ready, you may need to
get their
speak
attention.
really loudly to get their attention at first.
All right. If y'all are ready.
Turn that one off?
Not yet.
Yeah, we didn't hear.
You're good.
Michelle's bringing it. See, they kind of go this time.
Good afternoon, everyone. Welcome to lunch. My name's Charlie Strange. I'm a pulmonary specialist from Charleston, South Carolina. I work at the Medical University of South Carolina there. I've been there for only 34 years, all in one place. And one of my jobs there is to educate our medical center about COPD. So that's what we're going to try and do today. It's a really big topic. And I realize that we have a very multidisciplinary our audience here. But that's what COPD is about, because it really touches every one of us in what we do, whether we're a surgeon or an OR staff, just because of the prevalence of disease. And I'll show you the state of Alabama and how much COPD you have here. I think you're the epicenter of all of COPD in the whole United States. So this is all good. I do have some disclosures. I ran a rare genetic disease registry called the Alpha-1 registry for a rare genetic form of COPD I'm going to tell you about. For 19 years, I do a bunch of clinical trials in Alpha-1, and I consult for all the pharma companies that make drugs for COPD. Without drugs, we don't have too many therapies. We'll touch on all the non-drug therapies too. But I really want to be unbiased in my presentation. I'll show you the dirt and the good about all these drugs. And so it's all about preventing exacerbations and what Ascension Health is going to do there as well. So those are my disclosures. Our learning objectives, we have to touch a little bit on asthma too, because anything that has shortness of breath and cough and wheeze could be either chronic obstructive pulmonary disease or asthma. I think most of the time when we're younger than age 18, we're going to call it asthma. My Alpha-1 patients don't start wheezing with their COPD till about age 20. So making these distinctions gets a little fuzzy in the mid-range of life, and we'll talk about some of that. So this comes with a big agenda. There's the National Institute of Health, the CDC, the COPD Foundation, a not-for-profit, all get together about once a year, and they use some of the CDC's workings to figure out how much COPD is out there. And it's a big chunk. We recognize there's many people undiagnosed as there are diagnosed with COPD, almost. What does that mean for all of us? If your chart pops up and it says COPD, we know that 30% of the people that have COPD on their medical record have a misdiagnosis. So that's how bad we do as a medical community getting the diagnosis right. And we're going to talk in a minute about spirometry, but we have this large undiagnosed population. We have an overdiagnosed population because everything that coughs and wheezes is not necessarily COPD. And 70% of patients with COPD are in the workforce. They're you and me. They're the nurses that started smoking a little bit when they were in nursing school and hadn't quite quit until they're 40, and now they're 65. And 25 years later, those impacts are showing themselves in their lungs. Last year, COPD slipped to being from number 3 killer in America to number 4. Number 3 was the upcoming movement of accidents, including the opioid crisis. So opioid crisis overtook COPD, but it's still $50 billion a year that we spend on this disease. So what do we know about it? Well, it is a disease of aging. We'll show that in another slide in just a minute. Women have higher death rates from COPD than men. It used to be this old man smoker's disease. We think that's because women have smaller lungs, and therefore the effects of smoking will affect them disproportionately. 43% of people saw a doctor in the past year. What does that mean? Well, 60% didn't, and that's an opportunity when you serve in a population like Ascension does. And about a quarter of those people show up at the ER or hospital every year. This is a slide out of a new initiative that Ascension Health asked me to show to you because it just tells you the same sort of things I just told you, but it's part of a new initiative because every healthcare community in America gets challenged by the federal government to do a good job with our COPD readmissions. We don't want to discharge somebody and have them come back 2 weeks later into our hospital, or else you as a hospital system pay a penalty for that. And so there are only 2,000 persons with COPD within the Ascension system that fall into this bundle as we know it right now. And so what's going to happen next year is that they put together a fiscal year 20 asthma and COPD priority goal to try and decrease hospital admissions by 6% for the whole health system around Birmingham. And how are they going to do that? Well, you can either attack your admission rates by improving the denominator. That means you diagnose a whole lot more people with COPD that are in the works that really don't have very bad COPD, or you try and work on those people that are the frequent flyers in the emergency room, which is sometimes a very, very hard nut to crack. And there is obviously a hospice initiative in here built in. The evaluation period is everybody that has COPD identified in 2019, and then attack 2020 and see what we can do as a healthcare system. It's a tall order. It's obviously put together by the guys that count the beans, but beans are important, as we all know, in American health these days. And so we'll take any questions that we have about how to do this better at the end of the talk. All right, let's get the diagnosis right. Diagnosis is by a fancy test called spirometry. Do we make other medical diagnoses by tests in America today? How about diabetes? What do? Glucose and A1C. COPD, FEV1, FVC ratio. It defines the disease. It is the diagnosis. And in any healthcare system in America, we have about 30% of people that have COPD on their chart that have never had a spirometry. And to us, as pulmonary specialists, we've been fighting this battle for 20 years. We think it's dismal. It's something we can do better at. And I'm sure there's a spirometry lab in the hospital. Any of the respiratory therapists that run the spirometry here? An opportunity. So let's all do a spirometry maneuver. It has a few components. Biggest breath you can. We're going to blast it out for 6 long seconds as hard as you can. Go, blow. 2, 3, 4, 5, 6. Full inspiration. And you just did it. And only one person coughed. All right. The point is that we're trying to figure out how fast that air comes out of your lungs. And these people with airways disease of COPD can't get the air out through their ways fast enough, although eventually if they blow it out long enough, they can. This is called obstruction. What comes out fast in 1 second is called the forced expiratory volume in 1 second. What eventually comes out is the forced vital capacity, and that ratio defines whether you have obstruction or not. If you don't have obstruction, you don't have COPD. You can have asthma that's fully treated and reversible, but you don't have COPD. Now let's talk about what happens if you have a bad scar in lung disease, idiopathic pulmonary fibrosis. Will your FEV1 fall? Well, it will, but the volume axis will often fall. As you scar your lungs, you can't take that big breath anymore, so your forced vital capacity also falls. And what that does, it means that your FEV1 can never be higher than your FVC, so your ratio between FEV1 and FVC still stays good, greater than 70%. But when you can't get it out through your airways, obstruction is an airways disease. And so your FEV1 divided by your FVC has to then drop. And what this looks like in our algorithms, our gold guidelines, is this process by which the FEV1-FVC ratio less than 0.7 defines obstruction, and then we use that FEV1 as a percent predicted to set how bad your obstruction is. And these very severe guys, less than 30%, everybody recognizes. We have a diagnostic rate of 95% with them. It's all the others that are severe, moderate, and mild that we misdiagnose. And yet the ER and hospitalization numbers are exactly equal between moderate, severe, and very severe patients. So it means we need to do a better job diagnosing people correctly so we get the right diagnosis. On the restrictive side, the FVC will fall, but our ratio stays normal. Okay, we have a set of guidelines in COPD. They're called the GOLD guidelines, the Global Initiative for Obstructive Lung Disease. They say this is a common, preventable, and treatable disease. You have to have some symptoms and airflow limitations. That means you have to have spirometry, and then it defines what it's due to, usually due to particles and or inhalational particles or gases that are noxious. Most common cause of COPD, I think we all in the room know, is smoking, and yet smoking only defines 75% of our COPD population. We have 25% of the COPD population that has never smoked a cigarette in their life. And so you can't use cigarettes alone as the way you make that diagnosis. It's the symptoms, particularly with aging, that then lends you to spirometry to get you in the right place with the right diagnosis. We have phenotypes or epitopes of COPD that people have heard about. If the blue box here is obstruction defined by spirometry, then that's our diagnostic group. But you can get there by having holes in your lung of emphysema. We'll show you some pictures of that. You can get there by having lots of mucus in your airways, collapsible airways, inflamed airways, a thing called chronic bronchitis. We'll show you some pictures of that. And you can get there by having persistent asthma that lends itself to irreversibility of airflow obstruction. So the way that works is that if you have asthma, and you've had asthma all your life, and we give you inhaled steroids and you can normalize your lung function, then you still have asthma alone. But when you can't normalize your lung function because of scarring in your airways or persistence of inflammation in your airways that despite adequate therapy, then that becomes chronic obstructive pulmonary disease. And we recognize there's this gray area where people have a whole lot of symptoms of asthma, the episodic nature, the seasonal nature. But if you can't get your spirometry back to normal, then we call you having the overlap syndrome. The COPD asthma COPD overlap ACO syndrome is now recognized and defined by our GOLD guidelines as a whole separate group. So those are the people that have asthma but also have fixed airflow obstruction that now are part of COPD. Okay, well here's the map of Alabama. This is an older map from 2011, but it hasn't really changed very much because the CDC only goes out and does spirometry at the house about every 10 to 15 years. And so this is the way we figure out what the map looks like, because it's hard to take a spirometer and knock on somebody's door, hey, you want to do a test, and come in and get actual data. But this is the data map of where COPD lives in America. It's heavily influenced by the tobacco belt, and here's Alabama with lots of dark spots in here that says that the prevalence by county is more than 13%. So it's not such a bad place to go looking for the disease. As y'all know, smoking's bad. I think you ask people out on the street, is smoking bad? Every one of them says yes. And so why didn't you quit when the Surgeon General in 1965 told you that smoking's bad? Well, you know, it's one of those things. It's hard to quit, and yet if you were to take every smoker and run them through a spirometry laboratory, we could find 75% of our cases of COPD. That's not recommended, because if you smoked more than 10 pack years, a pack a day for a year is a pack year, more than 10 pack years, only 15% of people get COPD. So that's why grandma can have smoked till she's 92 and do just fine. It means that if you run somebody with a smoking history and a cough into a spirometry laboratory, and they come up and they say, here's my perfect spirometry, what are you going to say? Keep on smoking? No, you're going to say that we've got other risks. We have lung cancer risk, we have ischemic heart disease risk, and COPD, number 3 disease on the list of frequency of smoking-related diseases that we're all carrying about in our patient population. So just recognize that not everybody that smokes gets COPD, and I think this whole conundrum around just because you smoked a lot and you have some shortness of breath doesn't mean you can't have heart failure is the cause of that. And so we'll often be getting BNPs and other tests, echocardiograms at time of wheezing in the ED to try and figure out how much of this is really COPD and how much can be other diagnoses within our medical system. Well, the last time we took spirometry out to patients' homes and knocked on the door was a study called NHANES. David Menino was working in the CDC at the time, and what he showed was that by strata of age, the patients that had gold stage 2 or higher, that means an FEV1 less than 80% with COPD, was on average only 5.2% across America at the time. But over the age of 45, that went up to 7.2. Over the age of 75, that number goes up to 22% of the whole entire population. So how many of these people do we see in the hospital that are over age 75? Well, it's half of our population, right? So that means that a quarter of the people that you see and touch, whether here for their prostate care, whether they're here for their a burn or whatever you're treating them for, are going to have COPD. And so how do you get at that piece? Who has it, who doesn't have it? The reason that CDC put gold stage 2 or higher into this mix was that at gold stage 2 is the point at which treatment makes a difference. So if you don't even know you have the disease, how are you going to get treated? Treatment decreases our exacerbation frequency. Exacerbations are the way we end up in the emergency department and in the hospital. So it's a call to action to understand how to find and identify that patient who just wants a Z-Pack because they have a little bronchitis and he's 64 years old, and it happens every year this time because all the kids go to school and it messes up the works. Your opportunity to get him into the spirometry laboratory, figure out if they have COPD, and go ahead and give him his Z-Pack, but bring him back and get his screening spirometry done for his symptomatic presentation. So people have said, well, spirometry is too hard. Why can't we just get a little questionnaire going? And so there have been a group at the NIH that have tried to do this. It's called the Captur Questionnaire. It's been validated. It's 5 questions. The problem with these questionnaires is that when you ask somebody with COPD, are you short of breath? 90% of them say, no, I'm not short of breath. And so you have to turn that question around. So if you put a bag of groceries in each hand and climb a flight of stairs, are you short of breath at the top of the stairs? And say, oh yeah, I can't do that. But they're not short of breath. And so how you frame your questions really, really matters in trying to figure out who has dyspnea. And a lot of people just think it's normative aging because lung function does decline with aging. And yet this is the way that we get at who's abnormal and who's not. The other question is open up beyond smoking. Have you ever worked in a place with dirty or polluted air, smoke, secondhand smoke, or dust? How many households in Birmingham have that answer? Yes. Yeah, that's a lot, right? So does your breathing change with seasons? Does it make it difficult to do things such as carrying? And compared to others your age, do you tire easy? It's not about shortness of breath, it's about getting tired. And so these were questions. They started with this huge bank and worked them down to find the most sensitive tests for COPD. And so that's the Captur Questionnaire. It's being validated in hospital systems. Spirometry is better. Captur is second best. All right, let's talk about emphysema. Emphysema means holes in the lungs. We look at holes in the lungs on only one test that we do, and it's because the holes are tiny. And when we take a picture of your chest with a chest x-ray, the air in the chest is black and you can't see the holes. So it really takes a chest CT to be able to sort out this. We do not have an indication to do a chest CT for COPD in America unless you've smoked in the past 10 years and enter our lung cancer screening programs. And so that whole process, the radiologists will describe the 4-millimeter nodule in slice number 52 in the left lower lobe, but sometimes they won't really comment on the emphysema that's there as well. So it's an opportunity to integrate our lung cancer screening and our programs at the radiology level. Our second big disease, chronic bronchitis, presence of a chronic productive cough in 3 months of 2 successive years. And this is the one that just comes and gets antibiotics now and again from the primary care offices around any healthcare system. It means that we have turned on, by cigarette smoking usually, these glands that are in our airways that are the mucus glands. And what happens as you smoke from age 15 to 25 to 35 is that those glands are being stimulated. They're being irritated by cigarette smoke. They hyperproduce mucus and the glands begin to grow. And you ask the 25-year-olds, can I quit, when are you going to quit smoking? Oh, when I have my first kid, I'm going to quit. And they do. But the glands keep growing, and what that means is when you stop smoking, that you're chronically then a mucus hyperproducing patient. And so you'll continue to cough up mucus the rest of your life because the glands have grown, and that's chronic bronchitis. Some of our experimental therapies here are going to be things like liquid nitrogen in the airways through bronchoscopy to decrease the glands, because we really don't have medicines for the mucus in the airways of these patients. Our anticholinergic medicines do decrease mucus production and bronchodilate. So our risk factor group looks at tobacco in any form. Hottest one, I guess, are some of these airway changes with inhaled vaping these days, although there are a lot of other diseases wrapped up into that. Marijuana's on the list. There are good studies now linking marijuana smoking, so if Alabama becomes a marijuana state, then you have to tell everybody to eat the gummy bears rather than smoke. Passive smoking is on this list, mainly in children. It's been very hard to prove passive smoking makes FEV1 change. Air pollution's on the list. There is signals around forest fires out west. The more twitchy your airways are, the higher the risk. We'll talk about alpha-1 in a second. HIV is on this list. It causes a form of emphysema. We have some rare diseases, Marfan's. We have a rare disease where you lose elastin called cutis laxa, and the lungs get holes in them like emphysema. Crack cocaine, IV Ritalin destroy the blood vessels, and when you lose blood vessels in your lungs, then the holes in the lungs fall after that as well. So my favorite disease, alpha-1, is a genetic disease and which is often misdiagnosed. Our American Thoracic Society guidelines have been out since 2003 that say everybody that has COPD needs a once-in-a-lifetime test for alpha-1. An alpha-1 blood level is run by every hospital lab in America. It costs $17. And if you have a very low alpha-1 is the second most abundant protein in our body that helps protect our lungs. Albumin is number one. Alpha-1 is a very abundant protein that helps protect our lungs from the effects of cigarette smoke. So if you are born genetically deficient in alpha-1 and at age 15 start picking up cigarettes and start coughing at age 20 and need a lung transplant at age 30, how many doctors do you think you need to see, and for how long before you get your alpha-1 level? And that study was first done at the Cleveland Clinic in 1994 and said you had to see 5 doctors and on average 7 years of misdiagnosis before somebody thought to think about this rare disease alpha-1 that makes up 1% of all of COPD. So if a disease makes up 1% of your patient population, is it worth testing for $17? The patients would say yes. The next question is, well, we only have 7,000 rare diseases. How good are we going to be at all of them? And not all of them have therapies like alpha-1. And so it engenders this longer conversation. We can take on that one in the discussion period. So this was a group of patients that have alpha-1. On the y-axis here is the FEV1% predicted, and this is their age. The smokers are in blue, the non-smokers are in red, and so we recognize that these really early onset 30-year-old emphysema patients probably had something wrong. I think everybody in the audience would say if you've got emphysema at age 30, that's a bad thing, and we ought to figure out why and send you to some specialty care. But how about this smoker at age 70 who smoked 15 years of cigarettes and has an 80% FEV1? Should he get tested? Oh no, he's got COPD from smoking, right? And so this heterogeneity across the population of smokers and non-smokers that develop emphysema is really quite amazing. And these were brothers and sisters. Obviously, the brother or sister came in as an index case because of very bad lung function, very advanced emphysema, usually associated with more smoking. But the people that smoked less and had less disease didn't get tested. And so we have now about 10% of our alpha-1 population diagnosed in America. We think that there are 90% of the patients that are in your COPD and asthma clinics that just need a once-in-a-lifetime $17 alpha-1 test to go forward. There are a lot of diseases, like liver disease, for instance, that we use blood tests to make the diagnosis. We're testing for hepatitis A, B, C, and hemochromatosis and all the other things. And in COPD, we don't really do the same thing quite as well. And what we do have is a list that's growing. We now know that the eosinophil-rich patient, everybody in the world gets a CBC with differential these days, but if you have more than 2% eosinophils, you're going to do worse with your COPD. You're going to show up at emergency departments. You're going to have exacerbations with higher frequency. And IgE elevations say that you probably have an asthma overlap. Those asthma overlap patients do tremendously worse as well with more ER and hospitalization risks. So that's our blood test for COPD list. We hope it grows. We're trying to find the other genetic causes of COPD, but that's what it is right now. And in our hospital system, when we write COPD, we go ahead and put the alpha-1 genotype right beside it, MM being the genotype of 94% of Americans. 6% of Americans have an abnormal alpha-1 genotype associated with some degree of either carrier state or the 1% of deficiencies. We just go on and write it, COPD alpha-1 MM genotype, and that way you know it's been tested, it's been done once in a lifetime, you never have to do it again. So that's alpha-1. So let's move on to our guidelines. The guidelines say that everybody needs a spirometrically confirmed diagnosis. Easy to say, very hard to do. The assessment of airflow limitation will then risk stratify your patients. But then we turn into this really complicated algorithm that I didn't personally embrace for the first 5 years, but I don't see it going away. It's an ABCD algorithm. It says that if you have symptoms that are minimal, that's a COPD assessment test score, or a modified medical research council score, a shortness of breath questionnaire score that is minimal, then you're in group A and C. But if you've got symptoms, you're going to be in B and D. And the other axis is your exacerbation history. Exacerbations have become so important in COPD care because we know that they worsen your outcomes. We'll talk more about exacerbation and exacerbation reduction here in a minute. But none or one minor one gets you in A or B. But if you've had at least one hospitalization, you can't be A and B anymore. You have to be C and D, or two that have been treated as an outpatient outside of the hospital or ED system will get you as the top tier here. So obviously the worst of our patients are all Ds. They have symptoms and frequent exacerbations. They're going to be in the hospital a lot. They're our target audience for a lot of research studies, but we don't want to leave behind what to do with the As and the Bs either. We have, up until last year, no generic inhalers at the FDA. What that meant is for the FDA to see a new medicine was that you had to take your medicine and take it with its own inhaler that was proprietary, hook them together, do clinical trials with both of them together to actually present and get license for, and what that led to was this proliferation of different kinds of inhalers, different ways, and those of you that are on the front lines kind of know this can sometimes be a nightmare, and we'll sometimes, for good at our jobs, have a patient take their inhaler rather than us giving it to them so we can actually see how good they are. I've always been impressed with the albuterol that goes under the arm, and the ones that puff it out here and breathe it in from like that, and so you'll be amazed if you start getting to do this. The dry powder inhalers, the aerosols, the HFAs are all different in their inhalation kinetics and how they work. I think the dry powder inhalers, that just make a big story short, is that we inhale those with as much vigor as we can. The aerosols, if you breathe them in too quickly, have a more inertial impaction in the back of our throat and they don't get inhaled, so that's a slow inhalation for all of our HFA and mist inhalers to get them optimally. All of our inhalers need the 10-second breath hold to let drugs sediment down into our small airways of our lungs where they do all their good business. So there's a lot of technique determination. Sometimes the pharmacists get involved in doing the trainings. You'd be amazed when you talk to the patient groups how many of them just got a prescription. They went to the pharmacy, there's nothing. They had to try and figure it out themselves, and I think that's what we're trying to avoid, particularly around the 10-second breath hold associated with each of these. The other piece is that our number of drugs keeps proliferating. So I've written here on the x-axis up here that the SABAs and SAMAs and the LABAs and the LAMAs. And so let's kind of get our abbreviations out of the way here. We have short-acting and long-acting inhalers. SABAs, short-acting bronchodilator beta agonists, are albuterol and their first cousins. Short-acting muscarinic antagonists are ipratropium and their first cousins. I just think I want to make a few points about albuterol first. It's used so often. Our 2 puffs of albuterol that we've used forever gives us 0.18 milligrams of drug. It is in small particles. It goes down into the lungs. It causes its bronchodilation within about 5 minutes. What do we do when we come to the emergency department? We give them a nebulizer of 2.5 milligrams or 28 puffs worth of albuterol. What you think? Are they going to get better? Yeah, probably. Could they have stayed at home and taken their 28 puffs of albuterol and gotten better? Yeah, that study's been done too. So why don't we just give them 28 puffs of albuterol in the emergency department? Well, we could, but we're coming to the hospital so we can improve our care. And we want to build the tools to prevent exacerbations, and that's not albuterol. These are long-acting strategies to stay maximally bronchodilated throughout the 24-hour period and not have exacerbations with any combination of long-acting medicines that we choose to deliver. Our long-acting beta agonists are a long list. Our LAMAs, or long-acting muscarinic antagonists like tiotropium or Spiriva, are increasingly a long list. And yet I've put the brand names down here that many of us in the room have not seen before because we have 18 new inhalers that have come out in the past 3 years. So that's in part of the problem, but it's also because we are combining the different classes of medicines. I think everybody in the room is familiar with inhaled corticosteroids and long-acting beta agonists because Advair and fluticasone and salmeterol has been out there for 20 years and has just gone generic. And so for the first time, we actually have a generic ICS-LABA out there. And I'll show you that in the next slide. The newest class of agents are saying, well, do our patients with COPD really need an inhaled steroid? And we recognize that inhaled steroids are the #1 drug for asthma. But yet, if you have emphysema or you don't cough and wheeze very much and you've not had exacerbations, inhaled steroids have a signal of increasing our infectious burden down our lungs and including pneumonias. And therefore, to take the inhaled corticosteroid out of the mix and just give a LABA all by itself is okay for COPD in the FDA's eyes. But for asthma, remember we had this big boxed warning around the SMART study in which GSK gave this Ceravent alone to 25,000 patients, increasing the death rate. Patients could bronchodilate for 12 hours and walk into some of their aerosol burdens. They can go and pet their cat and get these really bad exacerbations. Their asthma was very poorly controlled. And so we will not use LABAs alone for asthma. So what if we put a LAMA and a LABA together and give the best bronchodilator combination that we can and take the inhaled steroids alone? And so these are unique to COPD medicines. And there are now 4 of them out, and it is our recommended agent for patients who have not had an exacerbation. And I'll show you all the recommendations that come out of the guideline with that line of thinking. So what happens if you're on a LABA alone, a LAMA alone, or a LABA-LAMA, and you start having exacerbations? Well, then you add back the inhaled steroids. And so by doing this, we think that not everybody with COPD needs an ICS-LABA anymore as their mainstay of therapy. If you have asthma, that's different, and we're going to force the inhaled corticosteroid into the mix. What has come of our COPD patients that have asthma overlap when we try and compare these two classes of medicines is that it's only the people with eosinophilia on their CBC, defined as 2% or more, that really had the benefit of the ICS-LABA combination, where the inhaled steroid will actually decrease exacerbations. The history of asthma is often a little bit misfounded because a lot of people with COPD just have cough and wheeze associated with their disease. And so we've increasingly started looking at that CBC hidden in the record, almost everybody has one, and watched persistence of eosinophilia in a subgroup of the population over time is really the index population that almost has to have an inhaled steroid in the mix, and help sort it out that way. Our fluticasone propionate and salmeterol combinations, I think we knew as Advair Discus, Advair HFA. Teva came out with the Respaclick, and the new generic is the Wixela. This is the first time we've ever had a generic long-acting drug for COPD or for asthma, for that matter, on our formulary, and it's a big deal to the insurance companies. So increasingly, you're going to get lots of requests to use now more generic medicines. We think some of the LAMA medicines are on tap for going generic next year. So finally, at least one of the barriers to long-acting bronchodilator therapy in our COPD population has really been the cost of these inhalers that have been really quite high and have forced people into short-acting medicines that don't fulfill their true promise in exacerbation reduction. And so just recognize the medicines do make a difference in exacerbations. The FDA used to describe acute exacerbations of chronic bronchitis as an infectious disease. We now know that, for instance, air pollution can trigger these. And what happens when we start studying the germs versus just the airway inflammation that happens in COPD is that we used to think our lungs were pretty sterile. Now we know that our lungs have a natural microbiome that's about 20 germs or more in each of us, and it's all different. And what happens when you study one of these acute exacerbations is you actually have a bloom of one germ or more within there. In the United States, an acute exacerbation is treated with antibiotics 80% of the time. In the UK, acute exacerbations are treated with antibiotics 20% of the time. Outcomes were exactly the same. And so in our big mix to try and decrease pressure with antibiotics around acute exacerbations, we take the exacerbations that have purulent sputum, green or yellow sputum, and use those as the have-to-have antibiotics, and a lot of the others will get in steroids, short-course prednisone, intensified bronchodilators as our therapy of choice, is the new movement that's going on. How you do with that is a little bit different between the patients that have an FEV1 of 15% and are very fragile, and those that have more reserve, have a higher pulmonary reserve on the backside. Okay, so what happens to the patients that now need a LABA and a LAMA and now have an exacerbation? Well, they're going to end up on triple therapy, LAMA, LABA, and ICS therapy. And as many of you know, the first triple inhaler hit the market this year. This inhaler only cost $800. And so in comparing the triple versus using combinations of the other to allow the LABA-LAMA-ICS combination to actually be there in medication form, we get almost exactly the same benefits as long as patients are compliant. And so we don't really care how you get there, but people that are having exacerbations in the hospital, one hospitalized exacerbation, 2 outpatients, are going to move up that ABCD algorithm to actually being recommended to have triple combination therapy. It's the way we decrease exacerbations in this population most at risk and most costly for the institution and for payers. And the trials that were done only took 10,000 patients to compare the dual therapy versus the triple therapy. Came out in the New England Journal of Medicine late in 2018. But the triple combination actually won. This was the first trial that showed that medicines make a difference in mortality in COPD. We've never had, the cardiologists have all these 25,000 patient studies where they can show that this combination of drugs saves lives by decreasing myocardial infarction or heart failure exacerbation risk. Lung disease, we're lucky to get a 200-person study done, and yet that's changing these days. To actually study exacerbations in COPD, we need at least 2,000 patients in these studies, and finally there's enough bandwidth here to actually show some mortality improvements. So this was the study that showed that the triple combination had the lowest mortality over the 1-year period of the study compared to the other alternatives. And so you're going to see more triple therapy emerging because it saves exacerbation risks in all of our studies. So there's been this huge controversy around the ABCD groups and what we actually recommend, because we have very few comparative studies between different medicines within different groups. If we're going to define our groups by their phenotypes of symptomatic or exacerbation prone, then we ought to be doing our studies within those same groups. And so what the Gold Committee decided in January, which is where this study came from, or this recommendation came from, let's get primary care really initiated on the initial therapy. And so the initial therapy recommended for Group A, who are minimally symptomatic and aren't having exacerbation, you can use albuterol, you can have a bronchodilator. But if you're persistently symptomatic, you start with a long-acting bronchodilator. If you've had one exacerbation, you can start, if you don't have any symptoms after your exacerbation's over, with a LAMA alone, long-acting muscarinic antagonist. But if you're in Group D, we give you lots of choices, but it's going to end up with this is initial therapy. One more exacerbation while on initial therapy means you need to move up the ladder. And that moving up the ladder will end up being on triple therapy. And so they've taken a page from the asthma guidelines that have always been this circle in the middle where you review, you assess, you adjust your therapy to try and continually manage your cycle of patients to try and just make sure you're stepping up care when the next exacerbation happens. So what that means for patients that are admitted to St. Vincent's is that if somebody shows up in the emergency room with an exacerbation and they are on a long-acting agent, they need to leave on another long-acting agent in addition to what they've been on. They need to step up their therapy and then get back to make sure that it sticks, that they can afford it, all the things that come with continuing review, adjust, and assessment care. And so this is where we see a lot of discharge planning. Go back on your home medicines for your COPD isn't the recommendation. It means that to be able to move to the next level and decrease this $50 billion that we spend in COPD, you got to get people out of the emergency room and back into primary care where they're using more medicines than they were before. We have other things besides medicines that we use here, and I think this is one of the most important slides in the whole piece before we take questions here. And this starts with the smoking cessation bit. If we are successful at smoking cessation in the emergency department, we hardly make a difference in the number of exacerbations that then follow. Your exacerbation frequency has this much of it tied into the smoking. We put a whole lot of effort into smoking cessation for obvious reasons, for heart disease and lung cancer reduction. But once you've had your first COPD exacerbation that's in an emergency room, we're not going to tell you to keep smoking, but as part of the effort, but if you put all your efforts there, it's not as effective as if you put your efforts in all the other buckets here on this slide. And that includes pulmonary rehabilitation. Pulmonary rehab is a program of exercise. Medicare has this as a universal care in which you, as every Medicare patient in America, get 36 sessions of rehab. We bring our respiratory terrorists onto you with their big whips. We throw you on the treadmill. We get you going for 2 hours, 3 times a week for 3 months to get you exercising again. We try and exclude coronary disease before you throw you on the treadmill. We start slow. But the goal here is to actually make our patients have athlete's muscles. An athlete's muscle uses less oxygen. It produces less carbon dioxide. And with less carbon dioxide production, you have to breathe less hard. So now you have got an athlete's muscle under your body and really bad lungs. We do not improve lung function at all with pulmonary rehab, but patients can walk twice as far. That's 2 aisles of Walmart compared to 1 aisle of Walmart, and that's quality of life improvement, right? So it's really all about your exercise tolerance. So what does that mean when they ask for the parking sticker? No, we want you to park on the far side of the Walmart parking lot, right? We want grandma to walk as far as she can every day. It's this whole exercise agenda associated with getting your muscles better and some weight loss as well. So this whole process of improving diet, exercise, pulmonary rehab is really core. When people come to see me from all around for their COPD, every doctor in the world has done it right. They've packed the medicine list just full. And yet pulmonary rehab is the one intervention that almost nobody has done when they come to see me. It's the opportunity. It's been shown to decrease exacerbations, the goal of Ascension, and really decreases hospitalizations. We have not shown a mortality benefit yet. That's just because the studies aren't funded and done. Middle group are pharmaceutical approaches. We've talked about that. We're not going to talk about smoking cessation unless you have questions. And then it's the inhaler techniques, adherence to therapy, understanding all the multiple medications, the interaction with beta blockers, early recognition of exacerbations, treatment of exacerbations, and regular contact with your primary care. They're so important to making this all act like a village. I want to share just a few more pieces about the exacerbation and what it looks like, and I think you'll be a little bit surprised, but we think this is such an important part of COPD unless you kind of can, A, pronounce it. Patients can't pronounce exacerbation very well, so we all need to be able to pronounce exacerbation. But talk about it in the clinic, then you're not going to be as effective as a healthcare practitioner. And it's an acute worsening of respiratory symptoms that results in additional therapy over and above your baseline, and that can be as simple as more albuterol today, then that's an exacerbation. If we do studies on exacerbations, we have to do it with home diary cards or smart machines that you plug in some symptom scores, but they occur more frequently the worse you get with your lung function. This is the most common reason for hospitalizations. They're associated with decreases in health-related quality of life. They increase mortality if you have them, and they're the major price point. It's about 80% of our COPD budget is spent on COPD exacerbations. So if you've had a first hospitalized exacerbation, your median survival after that event is 3.6 years. What do you think about that? So how many cancer diagnoses, first cancer diagnosis, median survival? 2 to 3 years, same ballpark. So a COPD exacerbation is not just a bunch of inhalers, go home on a home nebulizer of Combivent. It's really a major event in these patients' lives. And with good care, you can then let them have no more exacerbations. So if you have a hospitalized exacerbation, 11% of those patients are going to die within 90 days. So think about these exacerbated patients in the wards a little bit differently if you just realize what these statistics really show. We manage these acutely with giving everybody a bunch of prednisone and giving them some antibiotics and lots of inhalers. But our maintenance therapies that decrease exacerbation are getting our flu shots, pulmonary rehab, self-management and support, however you do it within the healthcare system village, and pharmacotherapy with any long-acting bronchodilator in any combination. Long-acting bronchodilators, LABA by itself, LAMA by itself, combination ICS-LABA, LABA-LAMA, triple therapy. They all work. They all decrease exacerbations. If you have exacerbations on those, you step up to the next level, and that's the way it goes in this reassessment paradigm. I wanted to share with you some of the things, the fancy stuff they're doing downtown at UAB. They may be doing it here, I don't know. But we have a group of devices that have been trialed, and obviously there's lung transplantation. We knew about 15 years ago that if you have big hyperinflated lungs from emphysema, that if we go in and take a surgical staple and whack out a third of your lungs and throw them in the trash can to shrink your lungs, that we can improve your mortality over the next 7 years. That hyperinflated patient with an emphysema phenotype is pressed down his diaphragms, they can't breathe, and by restoring curvature of the diaphragm, letting them cough better, they will do better. But the problem with that is there's only a 5% mortality next week, Monday, when your surgery's scheduled. So what do you think, Ms. Jones? And about 200 patients a year have been done over the past decades in major surgical centers of America. So what has happened since is that we have developed some bronchoscopic devices that will cause lung volume reduction. The two that are licensed by the FDA are the Zephyr and the Spirometry Maneuver valve. The way this starts is you look at a CT scan, you can see all the holes of emphysema, the black parts of the lung, and figure out how much emphysema, where it is. You also should probably notice the pack of cigarettes sitting in this patient's pocket and get them to stop smoking before they get any of these procedures. We go in with the bronchoscope, we put in these little valves. They have little one-way valve characteristics. There's the one open, or the air can come out, but it can't go back in. We target these into the worst lobe of your emphysema so that no air can go into that lobe, and that lobe will pancake down. The rest of the lung will fill the space, the diaphragm will come up, the heart will shift over, and what happens is you have a patient that has many less symptoms and makes a very large impact on quality of life. And so these procedures are being done only for the hyperinflated patients with emphysema, very specific, maybe 5% of the patients that are out there with an emphysema phenotype. You have to have pretty bad lung disease, but you can't have too bad lung disease. So you can't have pulmonary hypertension. You can't have a diffusing capacity less than 20%. Your residual volume, that trapped gas in the emphysema holes, needs to be greater than 175% predicted. You have to have done pulmonary rehab and get in the mix. But I think y'all are getting the flavor by now that to do COPD well at a hospital system really takes a village. It's your discharge planners, it's your pharmacists, it's getting home care, palliative care coordinators, dietitians, your thought leaders all aligned in trying to do this well, recognizing COPD, make sure people have access to spirometry, think about the diagnosis, get a good diagnosis on the front side, make sure people have access to medicines. It really takes a village, and I think this slide actually came out of the Ascension Health's guide for COPD for 2020, so some of you may see this in a different form, but it's all about this new initiative where Ascension can save $1 million if we just do COPD a little bit better with better diagnosis and better care and exacerbation prevention, which is really the model that we all want to emulate as we head across COPD care. So in conclusion, it leaves us 5 minutes for questions. COPD medication management using the ABCD classification system isn't going to go away, so we ought to embrace it and try and adjust our medicines by it. We finally have genetic medications for COPD. That's a big cheer. And exacerbation prevention with daily long-acting medication saves money and probably improves mortality across more than just that one study that I showed you. So let me stop there and take questions, and we'll say thanks to the audience that was out there listening at the other hospitals too. Who's got questions? It's a lot of stuff to throw at you. Go for it.
I know Tammy Foven, she works in USC. She's a brand new music therapist. I wonder if you've had any experience or any opportunities with, patients who are musicians who have trouble singing with this kind of stuff.
Yeah, so the question is whether our new music therapist at Medical University of South Carolina, our work, is making an impact with our musicians who just happen to smoke a little bit. And she's been in our ICU almost every day playing to somebody or another with COPD and without. And we think that this whole trying to get in touch with what you really want to do in life is the way that you improve your care for your grandkids and you get your priorities right in life. So it's been very effective with that intervention and others to our palliative care experts or experts not necessarily at turning on hospice, but not that they couldn't, but with trying to make sure that patients are doing their COPD care right for the right reasons, that they don't end up in the hospital all the time and it makes a difference. So, but yes, she's a great asset. Thanks to us for stealing her away from you then. Yes?
Are there any, is there increased emphysema in dusty environments like deserts or other?
Yeah, the question is there increased emphysema around dusty environments, or do you see more in deserts? The problem with the third world, as you know, is almost everybody these days is picking up smoking. So the smoking rate in China is 80% of men, 5% of women. The smoking rate in the Ukraine is only in the affluent. In the United States, it's only in the disadvantaged. Around the world, our smoking behaviors are very, very odd. We've not been able to pick up one around desert environments, but we have a very, very strong signal around particulate inhalations. So steel mills of Birmingham and all the dust and dirt that comes out of the road crews and that sort of thing, even without cigarette smoking, is a very high risk for emphysema and for chronic bronchitis. It's one of our, the dusty environment piece is very real. How we do that around, at least in indoor environments, OSHA heavily regulates your particulate burdens these days. In the outside environments of construction, not so much. And so it is a risk factor. We like dust burdens to come down and be less in that population. Okay, well, thanks for having me. It's been my pleasure. Very welcome.
All right.
So if you will just introduce yourself, and then you can just start right into it.
All right, good. And this is live?
You're live.
Okay.
You're up. Yes. Hey, 1 second. Let me hit record right here. I'll get it. All right. Whenever you're ready.
All right, well, thank you. Well, welcome, everyone. Thank you so much for taking the time to be here today. I'm Bali Yahia. I'm an internal medicine infectious disease physician and have the privilege of being the chief medical officer for clinical network services at Ascension, which is really the family of our medical group, all of our doctors and caregivers and our population health arm. And I got a chance to talk today about clinician engagement and well-being, and I call it moving from the triple aim to the quadruple aim. And it's a topic that I think is very near and dear to my heart. And I think for many of the clinicians and administrators in the room, this is probably a conversation that you have not infrequently around how do we make sure that we have a healthy workforce so we can better take care of patients in our communities. So I have no conflicts of interest to disclose. I always start this talk with this picture, and I love this picture, and for some of folks might have seen it before, but this is probably the only kind of school-age picture that has been published in JAMA, which is a very top medical journal. It was published back in 2019, and it tells, I think, the story of why we're here today. You can see there is the patient, which is the little girl sitting on the exam table at the middle. And then right behind her is her mom, kind of reading a magazine, and her sister holding her brother. And do you know what who this individual represents? That's the doctor, back turned to the patient, kind of crouched over, typing on the computer. And there's a smile on his face, which I think is a positive, but it kind of really talks a little bit about where we are today. I think we want to communicate better, we want to engage with our patients, but there's things that get in the way, and some of them are documentation and working through the EHR. And I think a picture tells a 1,000 words. Now, this is interesting as well, because this is a picture not drawn by school-age child, but actually by a physician. And the National Academy of Medicine recently put out a big report on clinician engagement and well-being. And as part of that, they asked doctors to paint or draw what does burnout look like to them? How do you express it visually speaking? And this is called Woven. And I wanted to read this out for you. They asked a little bit about it. So it says, Woven represents the intricacies, layers, and complexities of feeling burned out while serving patients. It doesn't happen all at once, but builds over time. The shimmering threads represent life and hope that is embedded in each provider, the spirit of serving, and the belief that you will make a difference. All of these aspects woven together are the essence of the provider, which I think is very telling, because it's not all or none. Many times throughout our day, we have those glimmers of why we are doing what we're doing, caring for people, but at the same time, there's other layers in there that sometimes get in the way. So our objective today is really fourfold. So hopefully at the end of our conversation, you'll be able to understand a couple things. One is, what is the impact of clinician burnout to clinicians themselves, their families, our patients, and our organization? Understand the 3 domains of wellness, which we'll talk about. Describe some best practices that could be implemented at the hospital, clinic, and community level, and then think about how do we measure well-being, and how do we measure and track it over time. So I'll start with this concept of moving from the triple aim. This was an idea that came from the Institute for Healthcare Improvement, which is really thinking about patient satisfaction, outcomes, and providing affordable care value. But really, I think of all of those, especially the patient experience, as this 2 sides of the same coin with clinician engagement and well-being. We know that we're not going to be able to get the outcomes that we want for our patients in our communities. We're not going to get the satisfaction that we want, or frankly, value, without an engaged workforce. And I think that's very important. I love this quote here. It says, dissatisfied physicians and nurses are associated with lower patient satisfaction, may contribute to overuse of resources and thereby increase costs of care and reduce adherence to treatment plans, resulting in negatively affected clinical outcomes. So really, these are all interwoven together. And while today I'll be talking a lot about clinicians, physicians, nurses, and the care team, we know that if you're working in the healthcare space, they're not the only people that are impacted by burnout. And so while a lot of the data and the literature that I'm going to present today is based on those different communities, whether you're a medical assistant or others, you experience it as well. And so I just wanted to kind of make sure that we start with that. It's not just unique to the physicians. So what is burnout? It actually is a syndrome. It's characterized by exhaustion, cynicism, and reduced effectiveness. And over the last decade, there's been more and more studies about this condition. Different surveys report different findings, but almost about half of physicians are at either moderate or high risk of burnout. And here's a couple kind of data points for you. 68% of family physicians and 73% of general medicine, internal medicine doctors, when surveyed, said they would not choose the same specialty. Many of that related to their practice environment and feeling burned out. 87% of docs named the leading cause of work-related burnout was paperwork and administration. I think the things that keep them from interacting with why they entered medicine, which is taking care of patients. And dissatisfied physicians are 2 to 3 times more likely to leave practice. So when we think about the doctors that we need to take care of our communities and how do we build a robust medical group and system, that's a very high level of turnover. So what are the effects of burnout? And they can really be grouped into kind of 2 buckets. One is personal, and then one is professional. So we know that there's many different studies that have linked burnout with broken relationships, alcohol and substance abuse, increased risk of depression, and suicide. All of those rates are much higher in clinicians and physicians that are burned out than those that aren't. We also know from a patient and a professional perspective that burnout is linked with decreased quality of care and increased medical errors. It's also linked with decreased patient satisfaction scores. The productivity, burnout doctors are not as productive and don't see as many patients as those that are engaged. And we know that there's a higher turnover rate. And so this, in my mind, is not just about the doc or about the clinician. It really is about the patient. The reason why we focus about this is that we want a healthy workforce to take care of our patients and also to take care of our community. So it's not just a doctor heal thyself sort of thing. It really is focused on, it impacts so many different people. And so again, this talks a little bit more about that. I love this image because I think while we were talking about what are the causes of burnout, many of those things flipped around creates an engaged workforce, which is defined as vigor, dedication, and absorption. And if it goes one way, you might lead to a more burned out workforce. If it goes the other way, you'll lead to an engaged workforce. And I bet you many of these things will resonate with you, which is workload and job demands. If you have more of those, it leads people sometimes towards one or the other. The amount of control and flexibility you have in your job, I think, is a big impact. Work-life integration, how you're able to integrate kind of your time at work and your time at home. When you come to work, do you like coming to work? Do you like the people that you work with? Do you have a community and support? Does the organization that you work for, you work with, have the same values, culture, and culture that encourages you to flourish? Do you have the resources and the tools to do your job? And do you find meaning in what you do? And so you can imagine that if those things are off kilter, it might lead towards more burnout. Whereas if those things are in sync, you can get a very engaged workforce that allows folks to kind of live full lives and also helps take care of patients better. The one thing that I did want to mention is really at the top right-hand corner here is this concept of the 3 domains of wellness. And this is based on published literature from, a lot of them coming from Stanford University. And there's really 3 domains of wellness: creating a culture of wellness, focusing on improving practice efficiency, and developing personal resilience. So there's 3 things to think about. I think what's important here is this is not squarely in the court of the clinician or the caregiver. And I think approaches to burnout that just put the onus back on the doc don't work. And I always kind of give the example of like offering yoga classes is not going to solve this issue. You really need to tackle all 3 domains. How do we create an environment that we work in that supports people living healthy lives, full lives, satisfied lives? How do we remove barriers out of their way from a practice efficiency perspective, especially around the EHR, making it easier to do things that need to be done, making sure that the care team is working at top of license, and then personal resilience, which is I think about like gas in the tank. We're all going to have good days and bad days. How do we make sure we have enough gas in the tank for some of those bad days that we can kind of bounce back from that? So things like mindfulness and being able to integrate appropriate diet and exercise helps in that aspect. But you really need all 3. And so it is the responsibility of the organization, not only the part of the doc and the caregiver, to participate. And so in order to help think through that, we had a group across our National Ministry in Ascension, doctors, APPs, residents, leaders that came together and thought about, okay, well, what are the best practices that we have that we can share in each of these 3 domains? And we have those published in a playbook that is available to any of you that you can download. But I wanted to kind of share a little bit of like the table of contents of each of those different sections. So on the culture of wellness, there's some very tactical things that we can do to create a better culture. One of them, the easiest one, is launching a group of clinicians that focuses on this. And across our country now, more and more folks are launching clinician well-being committees, and in some organizations, they are hiring what's called like chief wellness officers that are focused specifically on this area. And really what they're doing is just coordinating a lot of those activities, thinking about what should we do first. And so I think that's a very basic step that could be done. I've seen these committees both at the hospital level, so it might be a group of leaders at the hospital, as well as kind of across our medical group. Another one might be clinician to clinician communication and connection strategies. This is important because the era where people would run across each other in the kind of the lunchroom is not the same. When you had docs that were seeing patients in the clinic and then rounding in the hospital, and we are missing out sometimes on the connections together. And so finding ways that you can connect professionally and personally is important, building that community. Ensuring confidential support is available. I think for many folks, there's always a hesitancy to talk about when they might have an issue. And so thinking through, well, how do we provide that lifeline? It could be within our system, it could be a state society, it could be a specialty society, it could be someone across the country. But I think being able to provide confidential support where people can honestly share what's going on without feeling that someone at work will know is important. Creating opportunities for clinicians to give feedback. I think as more and more groups start to work together as a group or consolidate, some of that autonomy isn't there as much. And so creating that feedback loop to administrators and others is important. Demonstrating value, and I think this is one of the things that's very important for caregivers and physicians and clinicians alike, which is we are not just cogs in the machine. We are people that are, we are professionals we love taking care of patients. That's our job. How do we make sure that we recognize each other and our teams from that aspect? Coaching and mentoring, I think, is very important, especially for young physicians. How do you deal with that? And there's been some really, really good stories across our markets, especially around the surgical community, when you actually have a surgical team start to come up, and what happens when there might have been a near miss, and how do you talk about that, and how do you create that culture? And I think having mentors is important. Providing support and training in clinician in in terms of safety, workforce violence, harassment, discrimination. I think this is all about creating safe spaces. How do we make sure we have the right safe spaces? And then the other two are really about work-life integration, which I think all of us could work on, of how do you best balance those? And then how do you actually create spaces within the hospital, within the clinic, that are conducive for wellness? Many folks have some sort of innovation lounge, or where you might have ways, a space that allows you to just take a breath, to be able to have a huddle or a meeting that is not on the wards or is not in the cafeteria. And so all of these different things kind of play into place. When it comes to efficiency of practice, these things are very tactical ideas of how do we make practice more efficient. And I'll just highlight a couple. On the outpatient side, pre-visit planning, being able to understand what a patient needs or the patients that are going to be seen the next day need is really helpful, so that when they come in, you're not running around trying to order 5 labs and an x-ray. You have all those things done so that you can actually do all the job that you need to do when that patient is there. And so how do you implement that? Pre-appointment lab work and protocols, just like I talked about. Rooming and discharge strategies, both from an inpatient and an outpatient side. How do you get people in and out? Because many times you'll see our nurses trying to room people in the clinic, or our doctors discharging folks from the clinic as well, whereas how do we work at top of license and make it more run like a smooth machine? Huddles, very important. Open communication, sharing what's needed, who's on first, who's out today. You know, it doesn't need to take long, but that communication is important. Medication refill policies. These I think are really neat, because in a couple of our markets, some of the best practices are if a patient is calling for a med refill and it's getting to the doctor in that phone call message or through an email, that's a failure in their system, because they've come up with a way to make sure that they're constantly refilled, and they're communicating that the doc does not have to answer those calls or those emails, because we're preventing them. And so I think there are ways that we can do that. It helps our patients make sure that they have what they need to stay healthy, but also reduces the workload in the clinic. Synchronized prescription renewal protocols, those are kind of related, of how do you automatically renew things based on certain standards. Electronic prescribing for controlled substances. There's more opportunities here where you can actually electronically sign for different controlled substances versus using paper scripts. Unnecessary clinician work through inbox management. This is something that I think is very, very important, because I hear this all the time from our doctors. You know, we look at how many patients they see in a day, and they're like, oh, this was a busy day, but guess what? They have just as many things to do to manage their inbox, and so do our nurses, and so do our clerks and others. That sometimes doesn't get counted as part of the work, and can take longer answering all those messages, and figuring out how you do that in a way that, like I said, pushes and delegates some of those messages to the right person. Things that scheduling go to scheduling, things that can be handled by a nurse go to a nurse, things that need a doctor go to the doctor. That's very important and can help create better quality of life. Implementing our leading with quality, which is really how do we focus on quality improvement. I was doing a town hall in one of our markets, and one of the docs stood up and said, you know, what would improve my quality of life is keeping RMAs. I mean, it is so important. We see such turnover in our medical assistants sometimes that they are a critical part of the team. And so thinking through how we can develop and grow our medical assistants, how we can keep them within our system and let them kind of develop will be important. And then for those that are in Athena, which I know you are in here, how do you leverage the Athena Quality tab to close certain care gaps that close them the first time so you don't have to kind of follow up on them in future? So those are just a couple ideas. There's many more that aren't on there, but these are very tactical, tangible things that a clinic or a ward can do to start to execute on. And our toolkit has all these different protocols in there and examples from across the country. And then for personal resilience, a couple things. Mindfulness has been, in the literature, has really been linked to developing some of those resilience. So there's many different apps that you can probably download. You've probably seen ads for them, Calm or others like that. Those are some things that you can do, or how do you practice that, taking some time for yourself. Stress management training and services. This next one is thinking about your practice differently. We have a couple of our doctors that, like, literally they are taking the feedback that they get from patients. So, sometimes we're always bombarded with, we got to do this or you got to complete that. Well, they're taking some of the notes that are coming either from call centers or in suggestion boxes or letters that they've gotten, and making them visible of why did we enter this profession, why do we do what we do, and making sure that we capture that. And I think finding different ways that we can share with each other is important. Community building opportunities, and then offer assessments for resiliency, and I'll share some of those. This is a little bit of what the playbook looks like I said, that's accessible to each of you. For the most part, each practice is on one page, and you can see the description, which talks about what it is, what are some key steps to implement it, what are some things that different folks have found as important success factors, and then resources. You can actually download, like this example of a well-being committee, you can download a charter and use that as the base for your charter. So we tried to keep it very tactical, so you can actually pull it down and use it. This is another one on clinician to clinician communication strategies. So for example, here we talk about create a physician-specific Yammer group, or kind of almost a social media page for folks to be able to communicate. You could adopt a ministry-wide text paging system so that folks can communicate better with each other than just through emails. Host social events, grand rounds, like the stuff that we're doing today, that brings people a little bit closer and starts conversations and connections. And then share and review clinical work through lounges. So those are just a couple examples that you can see. We talked a lot about huddles. I think this is one of the most important things, not only for the team to form, but for delivering excellent quality care. It really starts with communication. And so we talk very specifically about how can you do that, what are some huddle sheets you can download, how do you use it, and this is, again, like some keys for success, like you want a huddle leader, you want a standard approach. So it kind of sometimes when you think of it, you're like, oh yeah, that makes sense, but we've packaged it all up so you can just download that and use it with your team. This is the medication refill protocol that I had mentioned that we're implementing in multiple places, is getting rave reviews, the leading with quality. So again, these are just a couple different examples. I've mentioned most of these already, so I'm going to skip through them. I do want to mention a little bit about performance measures, because it's important, if something is important, it's important for us to measure it. And sometimes when we don't measure things, it's not top of mind. And so in this area of engagement and well-being, what do you measure? And I think there's a couple things that we can look at. The first is really, and I know this is a little bit hard to read, so I'll mention, is that we can pull data from the EHR, and that information is helpful for our clinicians. So again, thinking a little bit more of the outpatient side here. Many of our markets are on Athena, but also on Epic and Cerner. We can look at how long it takes for someone to close a note. We can look at how many times those notes are closed in the same day, how many times you have to go back and make an addendum to the note. We can look at something that's called Pajama Time. What's the time spent in the EHR outside of working hours? We can look at also like things that might help a doctor or a clinician accelerate their work. How many times are they using macros? How many keystrokes do they have? So these are things that you can pull from the EHR. And what our team has been able to do with each of the markets is really look at, create a report to think through, okay, well, who are our doctors that are maybe in the upper quartile on many of these measures? So they're spending a lot of time after hours, it's taking them a long time to complete each note, and they're making a lot of addendums. And being more proactive, reaching out to them and saying, hey, is there something that we can talk about? Is there something that we can help you? We use different tools, whether they're EHR enhancers or scribes or other technologies. So I think that's one thing that's important, is that this is not just a fluffy topic. There's ways that we can concretely look at things in the EHR and other things in measure that become important. The other thing to think about is really different surveys, and I'll mention a little bit about our well-being index at the end, but there are tools we can use to look at engagement of providers. We also have the Model Community Survey, which is kind of a longer survey for all of our employees to really think about, do we have the right culture that we're creating to promote well-being? And then some other very hard outcomes like physician retention and turnover. As I had mentioned before, folks that are more burned out are more likely to kind of rotate out or turn over. So what does our retention rate look like? How long are folks able to stay with us? So I think another kind of key facet here is to really not only work on some of the things that relate to the 3 domains, but think of some KPIs, key performance indicators in these areas to track. I did want to share a little bit about the National Academy of Medicine report. So the National Academy of Medicine is a austere group of doctors and nurses and leaders that puts out different reports. They're the ones, if you are familiar with the report To Err is Human, that really started the patient quality and safety movement years ago. And so they put out a report on how to design kind of well-being systems in the organization, and I'll have the link at the end of our presentation. But I think it's worth a look at, and at minimum looking at the executive summary. And so they looked at a couple features of aligning organizational structures and processes with values. We need to use a system approach, ensuring that the leadership at the top is committed to these efforts, enhancing meaning and purpose in work, adequate resources that we've talked about a little bit. Teamwork is very important, designing the right type of reward systems, and then really using a human-centered design. So these were some of the different principles. Now, these can apply for many things, right? And so they used those principles and came up with a couple key goals to reduce burnout and foster well-being. And they very much relate to the 3 domains, but I thought it would be helpful to kind of share those with you. One is to create positive work environments. And so really looking at how does the environment, the physical environment, as well as the cultural environment look like. Similarly, create positive learning environments. Many of our facilities, including the one here, we have trainees in there, and in medicine, it's really a lifelong learning. So how do we make sure that we create not only the right work environment, but also environment to learn and grow personally and professionally? Reduce administrative burnout. This is very important. It keeps coming back, right? This is, like I said, not just fluffy. This is not just yoga. We have to take tactical steps to improve workflows, improve the electronic health record, improve the team composition to get this work done. Enable technology solutions. I always say, how do we make the electronic health record a partner and not an adversary? Because many times it's working against us in achieving well-being. We need to figure out ways that technology becomes a partner, not the other way around. Provide support for clinicians and learners, and then really invest in research. This is a new area. Like, it's just starting to get legs over the last couple of years, but we know it impacts our patients, our doctors, our communities, and our organizations. And so there's more, we have a lot more questions and answers at this point. And then lastly, and then we'll open up to questions, is I do want to mention the Wellbeing Index, which is a tool available to all of you today. So the Wellbeing Index was developed out of the Mayo Clinic, and it's now used in multiple countries and multiple large institutions, academic, nonprofits, for-profits, large and small. It's offered by our national group at Ascension. It is anonymous, it's free, and it's voluntary. It's web-based and also app-based. It has 9 questions that have been validated in studies and are linked to all those different things that we had talked about. So they're not just 9 questions. We are able to report the data in aggregate. So if anything less than 5 responses, we cannot see. So it truly is meant to be a safe space for you to assess your well-being. And it's more than a survey. You get instantaneous results. So you actually take the 9 questions on your phone, You can see how you compare to Ascension physicians or learners or APPs, and you can also see where you are compared to the nationally. You can also look at it by specialty or by age or race, ethnicity, all these different demographic factors. And this is a little bit of the snapshot. This is kind of what the survey looks like. Some of the questions are, it's 7 questions for residents and 9 questions for physicians. And so during the past month, have you felt burned out at work? They're very simple yes, no questions. And this is one of the most important slides today. So if you're in the audience or if you're watching online, take a screenshot or pull out your phone and download the app. The app is called My Wellbeing, so you can get it from the App Store, or if you're online, it's mywellbeingindex.org /sign up. And this is cut off a little bit, but if you're a physician, type Ascension Physician, that's your code. If you're an APP, type Ascension APP, and if you're a resident or fellow, type Ascension Resident. Set up your account, and then you can take the survey as often as you want. The other really cool thing about this is that there are resources that you can access, both national and local. So it's not just an assessment tool, it is really, it's a resource as well. We don't have one for nurses yet and others. The index is working on those, and Ashley at Ascension, we're working on how do we provide similar resources to other caregivers. I go back again to my point earlier that this is not just unique to these 3 health professions. This impacts a lot of people. We're just working on figuring out how to build the data and the science for the other groups as well. I'll share a little bit about our results nationally. So over the last couple months, we've had a number of folks take it. So we've had about 760 doctors, 350 APPs, and 350 residents. Interestingly, males, or maybe not interestingly, males report a higher well-being than our female clinicians. Pediatrics is doing really well. Our pediatricians are happier or more engaged than the national average, whereas psychiatry, which you can imagine, especially we can hardly get people into psychiatry, sometimes feel very burned out. And when we look at the resources, stress and resilience, relationships and work-life balance, and career development are the 3 resources that are impacted the most. I do want to give a big shout out to the committee. This is, I'm presenting on behalf of a group of people that has really pulled this work together. You can see some of their names here, and frankly, many of this work is also in every individual state market. And so this is really a little bit of a team effort. And I think it's going to continue to grow. This is kind of version 1.0. And in the PowerPoint, and here's the link to our toolkit and playbook, as well as the new National Academy report, Taking Action Against Clinician Burnout. So with that, I'll end kind of like the formal presentation, but I'd love to have a conversation with you about any questions you might have, or your thoughts, or learnings in this area. Thank you. Any questions or?
I've got one.
Sure.
We're doing all these classes nationally in Ascension. Is there any plans for any follow-up to see how well this is working?
Some of the tactics?
Clinician well-being.
Yeah, I mean, I think we're in the early phases because we just are rolling this out, and we hope, over time, we're in the first phase of our index. And so part of the reason why we want everyone to kind of take it and encourage you to take it is that it helps build a little bit of a baseline. So are these things working or not working? So that when we measure it kind of, every 6 months or so, we get a sense of, are we moving the needle? I think some of the stuff, anecdotally, is really making an impact. So like some of these different practice efficiency examples that I gave, like the refill protocol or some of the huddles, the feedback that we're getting from folks that implement them are like, oh wow, like this really helps. Like this did reduce my my burnout or the amount of work that I'm doing. So I think this is it's a complicated journey because it involves the individuals, practice, the system, it's culture change. But for me, what I value most is that one, we have to start the conversation. We have to start creating that, each of us start to create those changes and start to kind of move the needle. It's one of those things that I think has not been addressed in many aspects, and it becomes very important that we do. Thank you. Yeah, please.
To the questionnaire that you just reviewed, you said that the initial indexes for physicians and providers.
Mm-hmm.
Do you have a timeline or a rollout plan for other questionnaires for nursing or other disciplines that feel as much burnout as physicians?
Exactly, yeah. I think it's, as I said before, this is not unique to them. They just started there. There is a group, Ascension has a Center of Excellence for Nursing that just got stood up, that's looking at what are the right tools. I'm not sure if it's going to be the Mayo Index. That company is working on developing other kind of formats, but they're definitely from the nursing perspective. There's a team right now that's working on that. I don't have the timeline, but it's like you said, it's an ICU nurses, all types of nurses, like sometimes even have higher rates than burnout than some of the studies that we have from doctors. So it's not unique to us. I think it's unique to healthcare, but not to the specific individual in the healthcare team. Yeah, good question. All right, well, thank you guys so much for your attention. I'll be around if you have any other questions, but thanks for taking the time today. Appreciate it.